I'm your substitute host. I'm Dr. Michael Vitiello. I'm co-director of the Northwest Geriatric Education Center. I'm going to be introducing today's speaker and then brokering the questions later. Really pleased to have Dr. William Phillips, who's professor of medicine and family medicine here at the University of Washington. Professor Phillips has worked in medical education and primary care research in the department since 1979. He's one of those rare birds. He's a native of Seattle. He graduated UW Medical School and also received a master's in public health from the University of Washington School of Public Health and Community Medicine. Residency trained and board certified in family medicine and in preventive medicine. For 20 years, he's practiced full spectrum family medicine in Seattle. His experience is broad, interests varied, and his work is interdisciplinary. And most important for us, getting the information directly from the horse's mouth, he's a member of the U.S. Preventive Services Task Force. Dr. Phillips.
Thank you very much for your kind introduction. It's my privilege to be with you today and share with you an update about the recommendations that come from the U.S. Preventive Services Task Force. I've been a member of the task force for the past year, and for the purposes of today's discussion, I pondered what's geriatric. So I decided geriatric's anybody older than me, and I'm just about to turn 64. So I hope that meets your definition as well. So the learning goals for today's session are listed here to outline the task force recommendation process so you understand how the decisions are made, to update key recent recommendations, and we're dealing with about 2 or 3 years worth of recommendations since this last update was provided to your group, so that could be a long list, but we'll make our way through the highlights of it, and to discuss special considerations for prevention when it comes to caring for older adults like me. I don't have any conflicts of interest to disclose. We're not talking about off-label uses of medications. And in terms of evidence-based information, all the information we talk about today comes from the task force, which is perhaps the essence of evidence-based medicine. So what is the task force? I know many of you are familiar, but perhaps not everybody, so let's start on the same base here. This group's been around for a fair amount of time. It was established by an act of Congress and still operates under a congressional charter since ¡84. It's an independent panel of medical public health experts. We don't work for the government. We are staffed by AHRQ, the Agency for Healthcare Research and Quality, but that's just an administrative setup. And the congressional mission for the task force is to improve the quality, safety, efficiency, and effectiveness of health care for all Americans. What does the task force do? It systematically reviews evidence for clinical preventive services, and those fall under 3 categories: screening tests, which is what we usually think of, also behavioral and counseling services for behavior change, which is perhaps where the biggest bang for the buck and the biggest clinical challenge is, and preventive medications as well. We don't deal with immunizations. That's a different agency that does that. Task force makes recommendation on services for adults and children, and importantly, people without symptoms. We're talking about screening healthy, asymptomatic people, not guidelines for caring for people with symptoms or illness. And all of the work is in the primary care setting. So that could be in the office of a primary care clinician, or it'd be something that would be reasonably referred from that office. It also sometimes includes settings like screening in schools or churches or community programs. And famously, we've come out with these recommendations. And this is what you see when you see a clinical recommendation. They're graded. We'll get more into the detail of this in a bit, but they're graded A, B, C, D. And to start off so that we know where we're going with these recommendations, a grade A means the evidence is strong, the benefit is high, and the task force recommends that it shall be provided. B is also recommended, but with moderate evidence or moderate benefit, so there's a little more room for judgment. C is one that has questionable evidence, uncertainty associated with it, so the recommendation is kind of iffy, and it depends upon the clinician's judgment of the patient's situation. Now I wanted to highlight D because just a couple years ago that changed. D is not recommended. Anything with a grade D is not recommended by the task force. It used to just be not recommended, but now a D actually means do not do. So it's not a neutral, no recommendation. It's a positive recommendation that you shall not provide it to the patient. Of course, there's still room for judgment and individuality, but that's the way to read those recommendations. And the most common of all grades is the I statement, which simply means that after a thorough review and weighing the benefits and harms, we judge that we're not able to make a recommendation based on sound evidence. So what is it the task force doesn't do? It's good to be clear about this as well. The task force doesn't conduct any original research. It analyzes and systematizes and synthesizes research, but we don't go out and do clinical studies. It does not consider financial impact of our decisions. Now, that may be an increasing problem and an obligation for the future, but it's clear that for policy decisions right now, the cost of the test or the financial impact of the clinical decision is not part of the balance we strike. We do not make coverage decisions. We just issue reports and recommendations and let Medicare, Medicaid, private insurers, whoever, decide what to do with the information. And we do not issue clinical guidelines for the care of patients with illness. There's sources for that, and other organizations do that. But we're talking about primary prevention. So we've been called a lot of things over time with a couple of historic sort of controversies, mammography and PSA testing for prostate cancer, most notable. People sometimes refer to this as the death panel. When politicians talk about the death panel, I'm never really sure who they're talking about, but they say they're talking about us. And clearly the task force is not a death panel. It can't function in that way. Again, we don't control patient care. We don't control coverage decisions. We just provide evidence-based information for clinicians and healthcare systems and patients to use. We're also not specialists issuing protocols for primary care people. We're a primary care-based, evidence-based group that does our best to figure out what's appropriate for the primary care setting. We're not part of Obamacare. We go way back before Obamacare. We go back before Obama. Our procedures continue to evolve, but we have nothing to do with Obamacare. It's not a closed-door secret panel. The whole process is transparent to the public, to a group of selected stakeholders that are public health and clinical people, to community groups, and to anybody in the public that cares to get online and look at the research plans, the research findings, the draft recommendations, or the final recommendations. And there are formal steps for public input at each of those steps along the way. And we're not some kind of federal agents out to cut costs. In fact, it's probably true that we increase costs. Who are these people? Well, most importantly, the group is carefully selected through a long, arduous process that I went through over a year ago to check out conflicts of interest, which can be broad and varied, not just financial conflicts or patents or some kind of a financial association, but there's lots of ways to be conflicted about one's ability to give a neutral recommendation, and we have a very clear process for avoiding those. We serve 4-year terms. We're unpaid, so there's no financial conflict or incentive there, certainly no incentive. And the people that are represented are listed here. They're primary care people, nursing, behavioral health. Occasionally specialists will be brought in for some recommendations or background information, but the synthesis of information and the formulation of a recommendation is done by primary care clinician, public health people. Okay, let's start with a case. This is Mrs. Abernathy. She's an 86-year-old widowed woman, and she just comes in saying, I want a preventive well-woman health maintenance checkup. So as you collect information from her, we learn that she has no signs or symptoms, no family history of cancer. She's had pap smears in the past. They've always been negative. She had a negative mammogram 5 years ago. She has been a smoker, but she quit 3 years ago after a 40-year past history of smoking. So the question to start our conversation off is, what are the preventive services that the task force would recommend for this patient? Now that could be a great long laundry list. So just for the focus of our discussion, I'll ask you to consider these. Does a woman in this situation need a pap smear, mammogram, chest x-ray, colonoscopy, screening for Alzheimer's disease, screening for ovarian cancer, or screening for alcohol misuse? I presume you're committing yourself to clinical decisions. And here's the answer according to our current recommendations. If we say that she is an 86-year-old female recent smoker, The answer is the double crossed out are things that we actually recommend against. So the task force recommend that she does not have a pap smear, recommend she does not have a mammogram. She doesn't need a chest x-ray, but one of the news flashes here is the task force really does now recommend annual screening with low-dose computed tomography. I will get into the detail of that. So that's probably news, and that's a new recommendation. Applies only to people with an extensive history of smoking. She should not have a colonoscopy. Alzheimer's disease is not recommended because the evidence base isn't very good. We'll review that. She should not have ovarian cancer. The evidence is that doesn't work and it wouldn't be to her benefit. But she should have screening for alcohol misuse and risky drinking behavior. So that's a nutshell related to a real person that might help us kind of orient ourselves to the conversation we'll have as we move through the process and the recent recommendations. So we're dedicated to the prospect of evidence-based medicine. This is the original definition by David Sackett, and it's important to say that there's room for integrating the best evidence as synthesized from the literature, plus clinical insight, patient perspectives, and individuality. And nobody that works in, fully understands evidence-based medicine would think that it's just a rote method of turning statistics about populations into care about individuals. Sometimes it looks that way in certain kind of guidelines, but we try to keep these values always in mind. It's all about balancing benefits and harms. What we look for is the net health benefit. Do we have sufficient evidence that the net health benefit will improve the outcomes for the given patient? Sometimes it's hard to keep in mind, but it's true that all interventions have harms, even simple tests. And primary prevention, which is what we're about, starts with asymptomatic people. You know, the clinical contract between clinician and patient is somewhat different. If a patient comes in with chills and fever, 102, hacking cough, and abnormal lung exam and has pneumonia, that patient's sick, that patient needs treatment. The relationship between the patient, the ill person, and the caregiver is the traditional medical relationships. There's informed consent and the usual considerations that I'm sure we're all trained in. However, if you think about the preventive visit and preventive services really start from a different place. Patient comes in totally happy and healthy. Doctor, what should I have? And so if the doctor, nurse, or clinician recommends a service to that person who didn't ask for it and who doesn't have a problem to which it's related, we better be reasonably sure that it's going to be to their benefit. So that's why the obligation is greater in the preventive services situation to cast this balance for net health benefit. All recommendations must not have just neutral or just suspected, but proven health benefits. What are the benefits of screening? Well, it's easy to think that the question is, does the diagnosis and treatment of this condition improve the outcome? Or does the earlier diagnosis improve the outcome? But those are not the questions. We always have to bear in mind that the key question is, does early diagnosis through screening, before the condition would otherwise become apparent to patient or clinician or family members, does that maneuver lead to an extra increment of improvement in patient-relevant outcomes? It's a very specific question. That's the evidence we need. And of course, as you might suspect, oftentimes the evidence that we want is not available. Keeping in mind the harms of screening. First, there's the hazards intrinsic to the test. If you're going to do a biopsy or a smear or this or that, it's always possible that the patient will be harmed by the procedure of doing the test. That's the easy one to keep in mind. There are, however, a whole clinical set of events that start with a positive PSA test or an abnormal mammogram. Those are two great examples because what comes next is not so simple. There's anxiety, cost, pain, risks. So there's the adverse effects of the tests and the treatments. And we'll talk about prostate-specific antigen in a bit, but there's a situation where the clear harms associated with treatment have to be put in the equation to balance against what possible benefits there might be. There's false positives. In the equation for mammography, one of the most important variables is how much you think the anxiety about a positive test is before you know it, it's cancer. And what's the cost to the woman of having a scar on her breast from a biopsy that was not otherwise occurred? You have to ask the patients or the economists how to put a dollar figure on that to put it into the equation. And that figure is a big driver of your final decision. There's labeling. If we take a whole group of the population and all of a sudden say, you are diabetic, imagine what that does to them, to their self-image, to the way they deal with employers and family and insurance companies. It diverts resources. And here I'm not talking about financial resources, although those should come into play for policy decisions. It's that every time I spend 20 minutes talking to a patient about PSA testing to try to explain the pros and cons, that's 20 minutes I'm not able to spend helping him quit smoking or discussing her husband's alcohol concerns. So we live to some degree, even with system improvements, in a zero-sum game. And every time we choose to do intervention A, it takes time and effort away from intervention B. And everybody I trust has seen a patient who started with a simple chest x-ray and ended up in the ICU doing badly after a lung biopsy and an A, B, C, and a big clinical cascade. So we see patients, especially elderly patients, whose story in the midst of this catastrophe started with what seemed like a harmless, simple intervention, including a screening test. And the best way to prevent those clinical cascades is to prevent the unnecessary test at the outset. So those are the harms. Here's more detail for you. You might want to check this later. This is the actual definition of the grades. At this point, let me say, there's a slide set that goes along with this. It's probably in your inbox in your email. So it has all these slides plus other material. We will only be able to talk today about selected of the recommendations. So all the other relevant recommendations to this age group that I've listed for us, but won't have time to talk about, they're at the end of the slide set. There's also some selected references and resources that I guarantee you will be useful. That includes some special information about preventive considerations for older adults. So what we show and are able to cover today is only part of the package you have in hand. Now, it's important to understand this as the key to the process that the task force uses. This is a 2x2 table, and the two dimensions are certainty of net benefit on the left column. That is, as we review the literature and take all the data into account, what is our certainty about the benefit? We got data on the harms, data on the benefits, put that into the equation and come up with that. So that's an assessment of our knowledge. Across the top is the magnitude of benefit. That is, given our best point estimate and uncertainty estimate around that point, is this a big benefit or a little benefit? And those are the two variables that we use to determine which of the grades we give to it. So if we are very certain, have high certainty, that it has a substantial benefit, that earns the recommendation an A. And that's the only way you get to an A. If the certainty is less, moderate say, or the benefit is less, moderate, then you get a B. And we'll see some of those. If we're quite uncertain, if we're moderately uncertain and it has only a small benefit, then that's hard to be enthusiastic about that, and that earns a C. If we have any degree of certainty that there's harm done by the procedure, that earns the recommendation a D. And everything else, if we don't have a high or moderate degree of certainty, earns an I. We just don't feel comfortable about making a judgment. And those I's are not interpreted to mean they shouldn't be done, or they should be done, or they're good or they're bad. It's just that after our expert review, the evidence doesn't answer the question. You're on your own. Here's what it translates into practice. The A's and the B's are things you offer patients. The A's with more enthusiasm or directedness or more organized programs. The C is iffy, and therefore that's where, if you want to consider it, you should enter into a more partnership decision-making, shared decision-making conversation with the patient. And the obligation there is to tell them about both the benefits and the harms. And once you've done that, the patient's ready to make an informed decision. But if you're going to go ahead with the C, you'll probably want to cover both the benefits and harms. And D's, we discourage and you should discourage. Doesn't mean no patients will get them. There are individual circumstances, but they probably shouldn't get them because we lead the patient to believe that the evidence of benefit is certain and high. Now, we'll have time at the end for questions, and I know we're going to field questions from a multi-state region. So I just wanted to remind you to note some questions down for the end. This would be an appropriate time to ask what questions you have about the task force and its methods. Now we're going to go into recommendations for prevention for older adults. So it's a long list. It goes past this. Don't let this trouble you too much because we're not going to do it all. I do think we'll try to highlight, if time allows, the items in red. So if we look at recent recommendations, which I've gone back to 2012 for, so there's the 2012, the 2013, and a few that have already come up through 2014. There's this list, and we'll go through these. This is just kind of the table of contents. They're each listed here by topic with the year of the recommendation and the grade. So you see there's B's and I's and D's. There's a whole spectrum. Some of those are things we ought to be doing. Some of those things we ought to be not doing. And I'll focus on the ones where the directions are clearest and the import is the greatest. Here's the rest of that list. Here's where you see lung cancer is a B recommendation. Prostate cancer is a D recommendation. That is, don't do. So let's go through them category by category. The biggest obligation is for you to be up to date and know about the A recommendations. The good news is there are no new A recommendations. Now there's a long list of current A recommendations for adults, including older adults, longer than we want to go into here. Most of those you're familiar with. If you wanted to check this person, or any given person, or this example patient we have now, the easiest thing to do, and it's frighteningly easy, is to go to this EPSS, the Electronic Preventive Services Selector, which should reside on your smartphone or other device. You can go to the website and do it online, but it's actually a lot easier to do here. So you just put in age, sex, pregnant, yes or no, sexually active, yes or no, smoker, yes or no, and it generates a list of all the recommendations in each category, and you can follow through to get more data, information, and clinical tools. So if I could put this on the screen and dial in Mrs. Abercrombie, then we would have it for you. But we'll skip over that now because that's long, lengthy, and that's the part you're most likely to be familiar with already. So now we have a list of B recommendations. These are recommendations to do with more moderate certainty or more moderate benefit. Alcohol misuse screening and counseling. We'll talk a bit more about each of these red ones. Breast cancer risk assessment and preventive medicines. These turn out to be B recommendations and apply only to high-risk women, that is, women who have strong family histories of breast and ovarian cancer. So it's a subgroup. They are listed at the end of the slide pack if you want to look at those, but we'll skip over those for the because those don't apply to too many of our patients. Falls prevention in older adults, lung cancer screening, those are both new. Obesity screening is recommended, osteoporosis screening, and skin cancer prevention counseling. That's the list of new recommendations that came out for clinical services to apply to older adults. So let's go through them so you can hear the recommendation, get a little bit of background on each. So a recommendation is now out since 2013 for screening and behavioral counseling to reduce alcohol misuse or risky drinking. It applies to everyone over 18 to provide persons engaged in risky or hazardous drinking with brief behavioral counseling. And of course, to get the counseling, you need to identify the risk. Now, it turns out there's a lot of ways to identify the risk. They don't take too long. They can be done by the clinician or before the clinical visit in a primary care situation. The AUDIT screening tool is an easy one. The AUDIT-C is even shorter, but fascinatingly, a colleague of mine, a family medicine researcher in Missouri, did a study that's revealed here is that it turns out you can do all these fancy questionnaires, but they don't give you too much further than simply asking the patient, when's the last time you had 5 drinks at one go? And you don't need to listen to the answer. You just need to get the look on their face when you ask the question. Because the patient either says, huh? or they say, oh, well, let me see. If they say, let me see, then they've probably got a history of risky drinking. Now, to be a little more quantitative about it, it depends on kind of who you are. So the rule is 5 drinks for men, 4 drinks for women, or in the situation that we're talking about today, 4 drinks for somebody that's older than me. So it's a simple thing to do, and you can make a big change in somebody's life. The counseling doesn't have to be too intricate or expensive either. The behavioral counseling to reduce alcohol misuse has been proven to work. The best primary care type intervention is a brief multi-contact. So that is the clinician, doctor, or nurse on multiple occasions asking about drinking and using the 5A sort of a game plan to help the patient identify, commit to, and reduce their drinking. Prevention of falls in the community dwelling older adult. So the task force recommends exercise or physical therapy and vitamin D supplement to prevent falls in this group of patients. This is a B recommendation, so moderate certainty of moderate benefit. Turns out that either exercise or professional physical therapy has been proven to help prevent falls in older adults. It can be done from just a few hours of instruction and at-home exercises to a more intensive program of physical therapy. Both can have benefits. So again, it's a feasible thing to do. Now the vitamin D recommendations here, the RDA depends upon age. So for the people over 70 years, we're talking about 800 international units. It seems that within 12 months it makes a difference. And here's a bit that I learned that maybe you're way ahead of me on, is I kind of always had the idea that vitamin D was useful for older people because it made their bones stronger, so when they fell, they didn't fracture. But that's actually not the case. The evidence is that it doesn't do that very well. What it does is it makes them less likely to fall. The mechanism isn't clear. Is it a neurologic thing or a vision and hearing thing or some other mechanism? That's not clear. But vitamin D actually prevents falls. Now, what we don't recommend after a review of the evidence is one of these multidisciplinary, in-depth sort of assessment interventions as a screening measure for all older patients. Those are appropriate for some patients that are higher risk where those resources are available, but it's not a recommendation in general for practice. So now, screening for lung cancer. This is new and noteworthy. I have just a small audience here. Can someone tell me who this is? This famous smoker?
It's an author.
Yes, it is. Very good.
I don't remember who.
Now I think I can hear from Wyoming someone trying to shout. It's W.H. Auden. I always wondered why people had their portraits done holding a cigarette. It's a previous generation, I guess. Anyway, he's the guy who gets wrinklier and wrinklier if you see older portraits. So we have a recommendation now for screening on an annual basis for high-risk smokers with the new technology of low-dose computed CTs. Here's the text, and we'll go through it because it's a bit complex. So we recommend annual screening with this low-dose technique, and that's not just the general CT that you use for abdominal CTs. It's a special CT used mostly for heads, for chests. And now that this recommendation is out, this is the kind of impact these recommendations sometimes have. You can be pretty sure that your local medical center is going to have one of these machines. If you've got smokers, you're going to have one of these machines. So you'll have one. So in adults that are aged 55 to 80, you don't have to start till 55, and you can stop at 80. Those ages come from some mathematical modeling where we take the evidence available and construct computer models to tell us what the performance of the test would really be. And we're looking for those people that have a 30-year smoking history and either are current smokers or quit within 15 years. This seems like a checklist, but you'll get used to it. The notion is that if somebody smoked for 30 years and they're in this big age group between 55 and 80, they need one of these tests. If they're 85, they probably don't need it. If they're 45, they don't need it. If they smoked for 10 years, a long time ago, they don't need it. If they quit, like our patient did 3 years ago, that doesn't reduce their risk enough to forego this test. But if they said, I did 30 years of smoking and I quit when I'm 50 and now I'm 80, their risk has fallen down towards the normal non-smoking risk. And When you get past the 80 or past the 15, then you can stop doing it. So there is a termination point. This is probably the most detailed recommendation the task force have, with exactly who to get into the program and who to get out of the program. But this concept of when one stops screening is an important one, and it's important for the patient group we're talking today. There'll be a couple of other examples like this. So here's the way the review has gone. We all are worried about lung cancer. Lung cancer kills more Americans than breast cancer and colon cancer and prostate cancer put together. That's still true. It's a big burden of illness, disability, and death. So the important risk factors are age, total cumulative exposure. That's why we come up with those numbers about years of smoking, and the years since quitting smoking. The risk actually falls after you stop smoking. Other risk factors include certain occupations, radon exposure, family history, and some lung diseases. Now, this low-dose computed tomography has, in the published literature, in great big studies done in the U.S. and elsewhere, high sensitivity and acceptable specificity, so it functions with reasonable accuracy in the primary care circumstance for detecting lung cancer in this group of high-risk patients. And it's the only test that's recommended. Studies have been gone on over the last 40 years probably, looking for can we use chest x-rays in high-risk patients to screen, and that studies have all showed it doesn't work. So that's why this is a new recommendation. The new studies have been done with this new technology. So here's what a CAT scan might look like. You can see the cancer there, that little nodule in the patient's right lung. That's the right lung. But it's also got this cute addition. If you look up at the anterior chest on the left side of this image, the right side of this image, you can see the patient's cigarette lighter and his pack of smokes up there. So he's got 3 positive signs for lung cancer.
Those can be more easily removed.
That's right, yeah. We don't want to screen for a disease for which there's no effective treatment, and although there's a high mortality rate and most cancers of the lung come to light when they're too late for surgical cure, it is true that for non-small cell cancers that surgery is the treatment of choice, and it can be effective at cure if the tumor is small enough and it's found early enough. The evidence base looks like this. There's several large, high-quality randomized clinical trials. That's the gold standard evidence that we're always looking for. It reduced lung cancer mortality in a group of smokers by 20%. That's a big reduction. It reduced overall mortality by 7%. And there's a lot of interventions that, in which it's hard to prove that they reduce overall mortality at all, especially in older folks that have a lot of reasons to experience mortality. So the NNS, that's number needed to screen. Perhaps you're familiar with number needed to treat, number needed to test. Number needed to screen is 320. That means that if we instituted this program of annual screening in these patients, that you'd have to enroll 320 people into the program to get one life saved. That's a very low number. That is a very impressive finding. For mammograms, it's somewhere closer to 2,000. For colonoscopy, it's about a little bit over 1,000. So this number is way below that, and therefore, based on this evidence, this test is as good at doing its job of saving lives from lung cancer as those tests we commonly accept are for saving patients from those diseases. I just wanted to show you one of these plots. We work with these a lot, and you'll see them in the literature. So this is called a forest plot, and it's a meta-analysis. So this is where the investigators have taken all the studies, decided which ones are high quality enough to depend upon, and then instead of looking at 7 or 20 different studies, they're plotted onto this graph and then combined in a statistical fashion to give an answer of the effectiveness of the treatment or test for the aggregate data. Oftentimes, especially for rare conditions, studies, even reasonably big studies, don't have enough patients in them or enough events, in the case of rare events, to count them up and reach statistical significance. But a few thousand here, a few thousand there, pretty soon you're talking real ends. And if you get enough people assembled together, then you can make judgments about clinical and statistical significance from the group of studies where it wouldn't be well-founded to make those judgments on individual studies alone. So here what we see is these big studies. They've all got names. Almost always now the names are acronyms, so they're kind of classy and you can pronounce them. The NLSTT National Lung Screening Trial is that big box, and there's a vertical line over 1. And if a study shows that the effect is 1, the odds ratio is 1, that means it has no impact. If it's to the right of 1, the people are dying faster, and if it's to the left of 1, they're dying slower or lives are being saved. So the question is here, do these studies, with their center point of average and their dispersion reflected by these lines that go horizontally, where do they fall relative to 1? Well, it turns out the biggest study, the box, is a little bit to the left of 1. So is the diamond below it, etc. You can see the two ones that have the high degree of uncertainty, the long horizontal lines, they cross 1. That means that although they might have had a good impact, they didn't have the statistical significance to prove that. But if you add all these patients together, do the statistical maneuvers through meta-analysis and plot them on this forest plot, you end up with a diamond at the bottom. And the diamond is, the entirety of it is to the left, to the positive side, the curative side of 1, indicating that as a group, this data demonstrates that the patients who underwent these programs had lower than expected mortality. And the final number is 0.81. So that suggests that it saved about 20% of lives. I use this example because it's current, because it's somewhat controversial until you do this kind of analysis. And this is just an example of what we do with each of these problems if there's any data available at all. So what's the balance of harms and benefits? The answer is, after synthesis of this data and considering that balance, the task force's judgment was that we should recommend the annual screening with a low-dose CT. It's of moderate benefit for those asymptomatic patients who are at high risk based on these factors, which are age and smoking history. But I don't want to pass over lung cancer prevention by suggesting that screening is the way to prevent lung cancer. Until this recommendation and this research came out, we had no way to screen for lung cancer. We'd proven that chest x-ray didn't work, sputum cytology didn't work. So how do we prevent lung cancer? We prevent young people from not smoking. It's a policy decision. So there is a recommendation on counseling for prevent tobacco use and tobacco-caused disease. That's a different older guideline, but applies to all adults. And we really rely upon education, community-level programs, and in a bigger sense, advocacy and policy changes. I think it's remarkable how much of a social change there's been in acceptability of smoking behavior in our society just over the last 10 or 15 years. And as public health measures go, that's a pretty rapid turnaround. So there's hope. If there's hope for smoking, there's hope for other behaviors. Osteoporosis screening. This you're probably familiar with. It goes back to 2001, but I wanted to summarize it for the group because it's an important area of your clinical concern, I'm sure. So the current recommendation is that women over 65 years should be screened for osteoporosis with a DEXA scan. The information with regard to men and younger women is not sufficient to make a judgment about it all, except when you have a younger woman below 65 who you can estimate has a risk that's equal to 65. We're selecting people for their screening tests because of their risks. So we can arbitrarily, we can on the basis of evidence say that 65 is a reasonable cut point between low risk with less benefit, higher risk with more benefit. But if somebody else comes along and they have the same risk as a 65-year-old, then that quantitatively means they have the same benefit. And there's actually a way to do that. We'll get to that. The evidence synthesis goes like this. There's no controlled studies of screening. No one's ever done a study like I just showed you from lung cancer where you take several thousand people, put them in a screening program and see what happens to them. That hasn't been done, unfortunately. So that primo evidence isn't there for us. There is convincing evidence that drug therapies help reduce fractures if they're given to the right patients, so that's a potential benefit. And we know quite a bit about the harms, enough to make a judgment. The bisphosphonates aren't great of potential harm, and the estrogens and related medicines also have just moderate or smaller harms, and we have pretty good data on that. So the judgment was that there really was a net benefit to screening with the DEXA scan and treatment for those patients. So 65 is the guideline, but people with risk factors that equal 65 fall into that category, and this is probably the only graph I'll show, and this just suggests to you why that is the case. The dotted line on the bottom are women with risk factors. Those are the people that we know benefit from screening and treatment. They've been the ones in the trials. But if you look at the solid line, which is all the other women with no risk factors, you can see that somewhere between 60 and 64, they're just about equal. And so you can see that when you get to 65, it's reasonable to presume that all the women are just like the women that have had the risk factors been in the trials. And age alone is enough of a risk factor to justify it. So how do you tell if somebody's woman younger than 65 has risks equal or greater than 65? And the answer is you use an online tool, of which there are several, of which you can get it right off the EPSS thing on your phone while the patient's in front of you. And usually patients are impressed by you doing that. And you plug in the information that's here. This is one of the online predictors, and it tells you if their risk is high enough. With this model, if you get approximately a 10% risk fracture over the next 10 years, then that means they justify screening. This information is all here for you later, and as I say, you can find it online. So that covers the B recommendations. We've talked about all the A's and all the B's, all the recommendations to do things. The diciest thing in practice is the C recommendations. They don't have the solid evidence. They don't have the impressive benefits, so they call upon more judgment. Now, fortunately for our conversation today, there are no new C recommendations, so we'll skip over those. But these are often ones that require not only conversation to decide what your own clinical policy should be, but conversation with each individual patient to decide what's the right thing for that person in the context of their lives. So now we're going to go to the D recommendations, and these are the things that you should accept the recommendation not to use them. It's still your decision, but the recommendations are clear that the benefits are not outweighed by the harms, and the recommendation is do not use these. Some we won't talk about there at the end of the slide set. Cervical cancer screening in this age group. Coronary heart disease with ECG. It turns out the ECG is not useful for screening for anything. It's a useful clinical tool, but not to do on people just because they have a heart. Fracture prevention we'll talk about. Hormone replacement therapy you probably know about, and it's included, but we won't focus on it today. Ovarian cancer screening, which is very short. Prostate cancer screening, which can be very long if we can get the time. And supplements to prevent, vitamin supplements to prevent coronary vascular disease or cancer. The evidence says those don't work, and they should not be used. So now let's go through a couple of these. Fracture prevention in postmenopausal women. The current evidence, so these are all, these are D's, but this is a special case. I'll get to the D segment of this in a minute. So the general conclusion from the evidence review is that the evidence is insufficient for us to decide what the balance of benefits and harms is with regard to daily supplementation with vitamins and calcium. That's combined vitamin D and calcium, separate vitamin D at a sufficient dose, above the usual dose that's prescribed, and greater than 1,000 of calcium. So all of those things that we commonly have believed should help prevent fractures do not have supporting evidence to turn them into clinical policy. So insufficient evidence. And then if you look at supplementation with less than those amounts, that's actually been proven to not work. So we shouldn't do that. If you're going to do it, you need to discuss with the patient and pick a bigger dose. If you're having doses like this or lower, then that's something that's not recommended. This is an area where we actually have adequate evidence to say something's been tried and it doesn't work. Ovarian cancer screening, recommend against. Now, ovarian cancer is a big problem. It's got a high mortality rate. It's everybody's clinical nightmare. It's, if you're a female clinician, it's your own personal nightmare if you've seen patients with it. It would be nice to think that we have a test to prevent it, and the answer is we don't, or we don't yet. So the mortality rate's high, but the prevalence is actually relatively low, and for a screening test, that decreases what's called the predictive value. That is, if you do a test and it turns out positive, what's the actual chance that patient has the disease that she tested positive for? And the lower the prevalence, the lower the predictive value, and that means that you're more likely to give her a false positive answer. Put her through further testing and treatment, which in the case of ovarian cancer, it might be a big abdominal surgery. And it's unjustified at these rates. There is adequate evidence that screening doesn't make a difference. Now, 2 screening tests that have been promoted and tried and tested are ultrasonography, most recently transvaginal ultrasonography, and serum marker testing. Now, the biotechnology guys are always coming along saying, we've got a new multicolor, velocity-sensitive ultrasound that we're going to use, and it's going to be better. Or we've got a new 10-panel serum marker test. You see this in the newspaper all the time. But those things haven't been tested. They're based on these tests, which have been proven not to work. So until somebody comes up with some evidence that it really works, the recommendation is don't fool yourselves or patients into relying upon these tests. Prostate cancer screening. Now, I'd like to spend a little time on this for 2 reasons. One is it's a common concern and common clinical test for the older men in your patient population. Further, it's a huge controversy, one where the United States Preventive Services Task Force is, when they made their recommendation back in 2012, was way out on a limb and were highly criticized. Now, if you followed this, you'll see that other associations and bodies that issue recommendations have kind of fallen to the line and also agreed that PSA testing does not work with a sufficient benefit to outweigh the known harms. So, but it's been a controversy, and we can use it as an example of cancer screening and screening in general to see why we might make that judgment, especially in such a controversial area. So this is a D recommendation, don't do PSA screening. So everybody's worried about this iceberg of cancer, of which only a little bit is apparent. And everybody wants to find more cancers at an earlier point in their stage so they can be treated more effectively. We agree that that is the goal. But let's think about for a minute what's really under the iceberg there. There are these 4 categories of cancer. The first category are a group of cancers that are there. If you do biopsies, you might be able to find them, but they would never harm the patient. This is a little bit counterintuitive, particularly for patients, but it's clearly the case with prostate cancer. You've heard about the studies where young men dying in accidents have cancer of the prostate. And the prevalence of cancer lesions in a prostate found on autopsy go up linearly with age. So when you get to my age, the chance of having cancer in there, if you look for it with autopsy or biopsy, is as high perhaps as 40%. Now, are 40% of my group going to die of cancer of the prostate? The answer to that is clearly not. What happens to the others? The other ones are slow-growing, indolent cancers that will never cause me any symptoms. One would hope that we have a test to tell the indolent ones from the aggressive ones, and we don't. PSA doesn't do it, biopsy doesn't do it, histology doesn't do it, histochemistry doesn't do it. We don't have a method for doing that. So there is this group of cancers that would be best left alone, and if you knew who they were, you would best not look for. Now, of course, we don't know who they are, but in the biology of prostate cancer, in this example, the great majority of prostate cancers that can be found on biopsy or autopsy will never cause clinical illness in the patient. There's another category here listed as 2, cancers where the outcomes are good no matter what you do. So the cancer might become apparent, but you can treat it, and the patient gets better even without screening. What would be an example of that? Maybe non-melanoma skin cancers. They're pretty apparent. You find them. Maybe perhaps cervical cancer in today's world. You know, it's frequent to have cytologic abnormality. It's rare to have clinical disease or death from cervical cancer in our healthcare system. I've worked in underdeveloped countries where that's not true, but they have pretty good outcomes. Category 3, cancers for which early diagnosis through screening prolongs life. That's where the money is. That's what screening's aimed at. That's what we all want to do. And if my cancer was in that category, I'd want it found real soon and have it treated. But that's just one of the 3 categories. And then finally, there's this 4th group that it doesn't matter what you do, whether you find them early through screening or not, they're still fatal, and the testing and the treatment doesn't change the outcome. Cancer of the lung has been in that category until the new technology came along. Cancer of the ovary, cancer of the pancreas are two examples that are distressingly common, distressingly fatal diseases that we don't have a method. They are found late in their natural course because of their anatomic location and their biological behavior. They metastasize widely early. So there's those four categories in all cancers, but cancer of the pancreas. Now, only people in this third group benefit from screening. So if you have a lot of those people in the third group in a given cancer, that's what you're looking for. Cancer of the cervix, as the classic example, has a lot of category 3s. But for prostate, almost everybody is in category 1 or 2. Doesn't mean they don't have cancer. Doesn't mean that you wouldn't find it on a biopsy. It does mean that finding it on a biopsy and treating it early does not improve the outcome. Now, admittedly, we don't know which those patients are. And the clinical problem arises when you say, let's do a PSA, you do a biopsy, and I get a positive biopsy back as a patient. And I say, is this an important disease or not? And no one knows. So let me attach some numbers to this so you can see how the balance weighs out. This is we're looking at a 10-year reduced risk of dying from prostate cancer. That's a real outcome we're interested in. So if you don't do any screening at all, about 5 men in 1,000 in the older age group will die of prostate cancer. That's the problem. That's what we'd like to reduce. If you run a screening program, how many die? 5, or maybe 4. Maybe you save 1 life out of 1,000. That's the rate at which you were successful because so many of them don't need the treatment. So then the balance is men that avoid death from prostate cancer with the screening compared to without, and the answer is maybe 1 out of 1,000. So that's the benefit. That's what you could do, and 1 out of 1,000 maybe isn't too bad. That's, like I said, about colon cancer and mammography. But that's without considering the harms. So what are the harms? Well, we've got these false positives, which are distressingly common in 120 out of 1,000. You got to do something with false positives. At least you get in this stream of doing PSAs until you do the next thing. You hardly ever do PSAs until you do nothing. And what's the next thing? A prostate biopsy. And just talk to some guy who's had a prostate biopsy and think of 120 out of 1,000 requiring that. Then the men who are diagnosed with prostate cancer and undergo treatment turn out to be 110 of them, a lot of them, because everybody's got prostate cancer if you look for it. So that's the number of people who need treatment. And remember we said harms include the adverse effects of treatment. The more people you commit to treatment, the more people you can harm if there are harm associated with the treatment. So what's the story with prostate cancer treatment? Well, erectile dysfunction, which is the biggest concern most men will tell you about, occurs in almost 30 of the 1,000. Remember, we're saving 1 life and making 30 men permanently impotent. Another 18 are permanently incontinent of urine. Another 3 die or have a heart attack or a stroke or some terrible event during the treatment. And then other treatment complications like reactions of medicine and so on are rare, 1 out of 3,000. But if you add this all up, you see that if you do PSA screening for a period of 14 years, it's an interval for 1,000 men, the net results will be the following. You'll prevent 1 death due to prostate cancer. You'll make 30 or 40 men impotent, cause major complications in 3, and not change mortality a bit. So the summary is it's a situation where we have unknown benefits that are no better than very small, and known harms that are significant, both in terms of numbers and in terms of clinical impact on people's lives. But after they've been there, they're all cancer survivors, and they're all true believers, and they all know that they would have died of cancer if it had not been found with the PSA test and they'd not had the laser surgery with the robot and all that stuff. The evidence says otherwise, but individuals who've been through this experience, or even clinicians who've seen that with patients, just have to believe that it made a difference. Okay, let's go more quickly after we've covered these basic concepts that are so important through a couple other D recommendations. It turns out that when you look at vitamins, minerals, and multivitamin supplements for the purpose of preventing chronic illness, cardiovascular disease, and cancer, in general they don't work except for a statement about beta-carotene and vitamin E, which have actually been tried again and again and do not work In fact, in some populations, like lung cancer and smokers, actually raise the incidence. So if we want to prevent disease, we should not be recommending these particular two agents. And with regard to other vitamins and supplements, the answer is there's not enough evidence to support recommending those. Now we've got a long list of I statements. And some of these are interesting, even though they're I statements and end up with no specific recommendation. Here's the list. We'll go through a couple of the key ones shown here in red. The rest, they're all in the slide set, and you can look at those later. So why would you not use something that's an I statement? Why not just go with it if the patient wants it or if it's covered by insurance? And the answer is, as we said, everything has got complications, adverse effects, even simple tests. A PSA is a simple test to do. Permanent impotence is a hard thing to live with. The clinical cascade of events, things can get, in some patients, unpredictably, real bad, real fast, even though they started with a single, simple misstep. There's competing demands of practice, and if you do A, you can't do B, and with these, all the B's are more important. Worthless tasks that aren't supported by evidence displace valuable care. Your time with your patient is a very valuable asset, and we need to preserve it to let you do things that matter. What do you do with an I statement? Well, you can learn more about it by going online or wherever you see the recommendations and looking for the thing called the clinical considerations. That's where all the meat is. That isn't just the statistics and the meta-analysis and so on. So if you want to hear the pros and cons and the subgroups and more about the complexity of the clinical decision, there's usually a lot of helpful stuff, and it's put in this section called clinical considerations that is included in the outline of each of the recommendations. And if you do offer it, or if the patient wants it, it's probably our professional obligation to review the benefits and the harms. It shouldn't be, oh, if you want a PSA test, we'll do it. There's no evidence it helps. It should be, well, there's no evidence it helps, and have you considered that these are the things that could go wrong? If you weigh those and still want the test, I'd be happy to do it, but I'm obligated to tell you what the pros and cons are. Or sit down with this video or read this brochure. Here's another one that's of interest to us as we take care particularly of older, vulnerable older adults, or vulnerable adults that have disabilities or other functional impairments. It would be nice to think that we have a good tool that's been proven to work to screen those people who are in a domestic violence or elder abuse situation at home, but the answer is that we just don't have that tool yet. It's something to be sensitive to, it's something to listen for, maybe to ask about, but not to start up a systematic screening program. Cognitive impairment or Alzheimer's is one that's of great concern too, and the bottom line is that there's insufficient evidence to assess the balance of harms. So it's an I statement. Cognitive impairment with Alzheimer's disease and other kinds of dementia is clearly a big problem. It clearly goes up with age. In this, you'll see the figures there. It can go as high as a third of the population in the elderly years. And this concern about a condition short of Alzheimer's dementia that's been called mild cognitive impairment is also of concern, especially if you think we might have some intervention that would delay the onset or help people adjust to the disability that ensues. And the estimates of how common that is in our population are all over the map, 3% to 42%. There are detection tools. You can apply tools that are feasible to do, paper and pencil type tools or questionnaire type tools in primary care, and they have the sensitivity and specificity that we usually require something to be clinically useful. So it's not the identification of the patients that's the problem. The problem is that we don't have evidence that it makes a difference. So what you look for is to say, does a screening program change the outcomes, like it seems to for lung cancers and smokers and CT screening tests for lung cancer? The answer is that test has never been done for any kind of screening for dementia. We know that therapies have an effect, and those of you who have clinical experience know that patients are reaching and clinicians are hoping for effective therapies, and some therapies offer some benefit in some patients, but in studies and on a population basis, they help a small number of patients, a small amount, and only those patients who have mild to moderate dementia. and the help is delaying institutionalization for 3 months, well, that may be an important outcome, but it's a pretty small outcome to measure and to bank a program on. So the magnitude of how clinically relevant or life relevant that benefit is uncertain. It's hard to put the weight on that we would need to. There's also other interventions that aren't aimed at the patient, but they're aimed at the caregiver, the spouse, and so on. And if we could find something that would help them, that would be worthwhile too, but there's no studies that show that. The studies that look at it are quite equivocal. Some show a little benefit, most don't. The evidence just isn't there. And there's no evidence that knowing you're going to have, that you're headed towards Alzheimer's or have early impairment from cognitive impairment, there's no studies that show that helps patients or family members make plans, financial plans, life plans, or so on. Those are all worthwhile clinical endeavors, and we should be involved with them in our patient care, but we haven't found the evidence to support a systematic approach. The treatments have small benefits and significant potential harms. So it's an I statement, and we're hoping for something better. Glaucoma is another interesting I statement. Many of us have our patients get screened. Many of us go, depending on your age group, to the doctor and get glaucoma testing. No one wants to have glaucoma. No one wants to go blind. And we have to believe that early treatment prevents visual loss and that early diagnosis helps early treatment and that screening would make the diagnosis even earlier. That's the chain of reasoning, and the answer is there's no evidence that it works. The tests that we use in primary care, tonometry and so on, really don't have the test characteristics that justify their use. We know that there are treatments that are effective in reducing the intraocular pressure, but believe it or not, one of the limitations of the evidence is there's very little evidence that treating the patient before the patient or the spouse says, I've got a vision problem, makes a difference in the outcome of glaucoma treatment. Furthermore, when you treat glaucoma and save somebody's vision, there's very little evidence that there's really a change in the vision by the report of the patient. Are you driving? Are you going to Seahawks games? Do you spend time with your grandchildren? Is your functional status improved because your visual acuity is improved? That's the patient-centered outcome we'd like to hear, and almost all the studies that do deal with glaucoma don't look for those outcomes. That's a common problem. It's a place where the involvement of primary care clinicians and people with a patient perspective, patients themselves, if they were involved more in the planning and conduct of these studies, we get more patient-relevant outcomes that would give us the kind of evidence we want. There is a, separate from glaucoma, there's a recommendation on vision screening that's a couple years older, but it also found insufficient evidence. The people that, that do studies on older adult vision usually do not do studies on functional status. Now there's a list of things we're used to using in adults that have age restrictions on them, so these are kind of end dates for other screening tests. We won't discuss these, but there's a recommendation for HIV screening that usually ends at 65 unless your patient has special risks. Cervical cancer goes to 65. Skin cancer prevention applies only to people over 24, but it's an I. It doesn't have evidence to support it. Aspirin to prevent cardiovascular disease is recommended for adults, but only up to age 75. And why would it be that these have endpoints on them? That's a good example. Why would a 78-year-old not be helped by aspirin? Well, the usual answer is this. It's not that there's good evidence that the harm goes away or the benefit stops after 65. Like there was with the smokers in lung cancer, the usual story is that we have good evidence and the evidence stops at 75. The clinical trial did not enroll people over 75, or there were a very small number of older people, so we just can't extrapolate that data. And of course, aspirin has harms. Cumulatively, they seem small, but a lot of people suffer, and some people die from GI bleeding that's induced by aspirin, so it's not a harmless intervention. So that recommendation stops at 75. Colorectal cancer is a little more confusing and complicated regimen, but it drops down to a B recommendation after 75 and is recommended against after 85. The principle is You don't want to do a screening test on somebody to find a test to commit them to treatment if you don't feel that the patient will live long enough to benefit from the treatment, or their life is shortened or impaired in other ways so they would not benefit from the treatment. And abdominal aortic aneurysm. These recommendations are all at the end of your slide pack. Okay, we're getting ready for questions, so think about questions with regard to these recommendations. And I'll make a few more general points. How do you keep current? This is the way you do the patient care, because the tool is right there. If you want to know the current evidence in great detail about any of the things we've talked about, you go to the website. It's actually, for a government product, remarkably easy to use. It's made for the use of primary care clinicians and patients. I've got my trusty iPhone, but it fits on all platforms. So we've talked about some of these special challenges for older adults. Many diseases have multiple risk factors. You know, when we talk about preventing hip fractures, that's not just screening for osteoporosis or taking vitamin D or getting physical therapy. There's all sorts of clinical entities and clinical interventions that might contribute to the risk. So the task force tends to do this in a does test X, chest X-ray, prevent death from disease Y, lung cancer. And the methods work very well and have been tried and true and quite highly refined in that question. But that question is simpler than most of the patients we have, and especially older patients that have multi-morbidity, complex living circumstances, other limitations and impairments. It's the endeavor we're involved in with our patient care is more complicated than some of these analyses presume. That's a limitation. Interventions apply to multiple diseases, and multiple diseases can be affected by one intervention. The complexity is beyond what is imagined in that 2x2 table. Older adults often aren't represented in the evidence. They're excluded from the trials. They die before you get that old. They have multi-morbidity. If you're studying hypertension and you exclude all the diabetics and all the heart disease and all the COPDs, pretty soon you have hardly any people left at an advanced age. And so practically the evidence isn't there. And these important outcomes aren't included in the studies. Functional status, family adaptation, quality of life. I'll skip that. And this is true with all patients, particularly with older adults. It's important to consider what their attitudes and values are, and that deserves more study too. You know, if you're a young mom with a little kid at a well child exam, you have demonstrated that you've put a lot of value on preventive services. But if you're a 79-year-old smoker, risk taker with very limited activity in your life, the value you put on preventive services may be different. And of course, it's our obligation as clinicians to help understand that for each patient. But it's probably different and more wide-ranging among older adults than it is with some other people that are involved in our preventive services. So what do they think about the benefits and the harms? How well do they understand the benefits and harms? These concepts are remarkably difficult to get across, and they're anti-intuitive. Isn't it always better to find cancer early? It's hard to believe that the answer is no, especially when it's my cancer or when I already got my PSA test. So that the values and philosophy of evidence-based medicine are something we need to help patients understand, and it may be harder with some groups than others. Older adults may be among those groups. We talked about screening, medicine, and behavior and counseling. In reality, all preventive interventions are counseling. They're shared decision-making, they're talking, they're exploring values and decisions and coming up with a personalized plan. We give a report to Congress every year, and one of the most important things we can do is, on the basis of the frustrations we experience on these gaps in the evidence, the ones we've talked about today, outline areas for prime research, and these recommendations go to NIH, and we hope, presumably, will influence funding and stimulation for research. So our list this year includes cognitive impairment screening, We need better understanding of the natural history of the intervention for that. Screening for mental and physical well-being and functional status. Preventing falls is still confusing. And the screening for vision and hearing. It's inexcusable that we don't have evidence to really know how to help people preserve their ability to function in life with their special senses. That evidence isn't there. And helping people avoid unintended harms of medical procedures and testing. The last news item is that the whole game has changed with Obamacare. Now remember, we started before and we're not affiliated with that, but because we're there and because all the insurers, the government included, would like to have convenient ways to know what services to cover and what not to cover. Should they do bone marrow transplants for cancer of the breast? Should they do multiphasic behavioral interventions for kids with autism? All those kinds of very tough questions that are sometimes very expensive and almost always expensive in the aggregate. They have kicked the ball into our court, and the law itself declares that if the task force gives an A or B recommendation to preventive services, it must be covered by all insurances. That's why your community hospital will have a low-dose CT scanner. It's not something we ask for. It's maybe not something we're comfortable, but it doesn't really change what we do. We still work with the evidence we got to make the best synthetic decision we can. Early diagnosis is not always better. Screened disease is different than diagnosed disease. The prostate cancer that's found on a PSA is different than the one that's found on a rectal exam. All interventions have harms. Clinical cascades happen in real life. And we always need to keep in mind as we evaluate the evidence that there's a difference between a statement about the evidence of lack of effect and the lack of evidence of any effect. Thank you very much. And I'm happy to try to take some questions. I hope we have some stacked up.
Thank you, Dr. Phillips. We're going to shift now to the Q&A portion. We do have at least one in the queue, so if you have questions for Dr. Phillips, please type them in to your chat box. The first one is from Seward, Alaska, and the question is, if you have someone who is cognitively impaired, but it is due to an acute condition, say an adverse drug reaction or a tumor, why would screening not be important to rule that out?
Because screening is not the clinical task that's operative there. That's a matter of diagnosis, and screening and diagnosis are entirely different enterprises. So, as I said at the outset, and I'll reiterate now, is that all these recommendations don't have anything to do with sick patients or symptomatic patients. They're not meant to help you figure out what's wrong with a patient or how to manage a patient. They're aimed at finding, all screening tests are aimed at finding disease that exists in the patient before it's clinically evident to anybody, with the hope that treating it before it becomes apparent has a better outcome. So this patient's already sick. They need a good clinician and good care, but unfortunately our guidelines aren't going to be the guidance they need.
In this case, they would present with the cognitive impairment, and therefore it's well beyond screening, and it's into diagnosis and treatment.
That's right.
Stage. There is a comment from Palmer, Alaska, but I'm not quite sure what it means. Perhaps they could amplify it. I'm going to go on to the next question, which is, do recommendations on the web include effects of some positive risks on testing recommendations?
If I understand that right, yes, this balance we've been through of harms and benefits are outlined at length, much more length than I've given here for each of the recommendations. So you can go on the web and just get, the recommendation that I've tried to summarize here. And then there's the whole document that explains the rationale. There's a further part of the document that talks about clinical considerations. What do you do in this special situation? What do you do with that subgroup of patients? That's really where a lot of the use will come to our clinicians that want to look. And then, if you're really up for it and you're courageous, you can actually look at the entire evidence report that looks at all the studies, all the statistics, and you look at the original study and see, did this Italian study have patients in it like my practice? Those things, the text of them usually runs about 100 pages, and the whole thing runs about 200 or 300 pages, because they have all these charts and all these references. But the information's there. And by the way, if somebody wants to study up on one of these clinical conditions, or if somebody wants to do research and is looking for research topics and questions, go to the task force website, pick the condition, and you will find lots of grist there for learning and asking questions and study.
Okay, thank you. The next question is, do benefits outweigh negatives for lipid or cholesterol testing for residents over 65 years? That was the...
Can we go back to that one from Palmer?
Yeah, that's Palmer.
Oh, yeah.
Exactly.
I'm going to not answer that question because I don't know what the current answer is for two reasons. Number one is the task force right now, as everyone probably knows, the issue of the diagnosis, the screening, diagnosis, and management of lipids and lipid disorders is very controversial right now. Recent recommendations have come out saying the real question is not who's got abnormal lipids, but who should take a statin drug. So it's in flux. The task force right now, and I'm on this subcommittee, is revising our recommendations for lipid screening both in adults and in children, which is even a bit more problematic. One of the reasons this is so important is because everybody gets it, and the tests are expensive, and the drugs are very expensive. So before I commit myself as a patient or one of my patients to taking a drug that costs $5 or $40 every day for the rest of their life, I would like to know that it actually benefits them. And that question we know less about now than we did a year ago. So stay tuned.
May I ask a question?
Yes.
Because it's interesting you raised the whole idea of statins because there's been a shift. I know that I now qualify for statins where I didn't previously, but that doesn't come from you guys. That is coming from, I don't know, the cardiologists?
There's JNC7, the Joint National Committee, and there's well, let's summarize it that way, that there are many organizations that provide clinical practice guidelines apart from ours. Ours are all confined to prevention with those three modalities, medicine, screening, and counseling. We don't say anything about the treatment of hypertension and what you do with lipid abnormalities. Our question is, who shall you test? So there's a whole world of guidelines out there. One of the most helpful resources I put on here is just a website. It's easy. www.guidelines.gov is the government's national guideline clearinghouse that summarizes all the guidelines from reputable organizations all over the world. And they include not just screening and prevention, but management guidelines as well. So there are a lot of other players. Sometimes it boils down to differences between the players when it comes to prevention. Some people disagree with us. The most famous one has been with the American Association of Urology, which has always recommended PSA testing, although recently they've backed away from that as a universal recommendation.
The next question is, do you see the VHA adopting your organization's recommendations?
What's the Voluntary Hospital Association still? What is the
I'm thinking it's the veterans.
VA. That's the VA.
Yeah, well, there's an H in this, but I think it's VA.
I remember when I was studying hospital administration, VHA was the Voluntary Hospital Administration, but that was administration association. Well, the answer is the VA will do its best job of searching, evaluating, and deciding on their own guidelines. All big organizations do that. Group health does that, the military does that, health systems do that, and they don't always pick exactly ours. Sometimes they modify it, sometimes they take a middle position between the task force and some other group. Sometimes there's special considerations with regard to, well, let me give you an example. We're in the process right now of revising our screening recommendations for depression. Our question is, what shall we do with depression in the general population? In the Veterans Hospital Administration, they have a different population, they have a different profile of problems, and our recommendation might not fit their population. Now, the evidence that's summarized in our documents might be an asset to them to make up their own recommendations because the raw materials are there, but they might come to a different understanding and a different recommendation. So I wouldn't speak for the veterans. The answer probably is they'll pick some right off the shelf because the evidence just isn't there. They'll modify some based on sound policy decisions like the population they serve or on political considerations. At an organization like Group Health, consumer-driven HMO in Seattle, they also consider what the consumers want. They might take a vote on it.
There was a clarification for the question. It's Veterans Health Administration,
Yeah,
but
okay.
we're behind the curve, obviously. Okay, so Olympic Medical Center is asking, could you clarify vitamin D recommendations for women over 50? On one hand, you said it was recommended as a B, and then it came up as a D under osteoporosis screening. I think it's falls versus osteoporosis.
So I think I can do that. It is a bit potentially confusion. The answer is, if you give the lower doses, below 400 of D and 1,000 of calcium, that's been tested and it does not work. So the recommendation, that's a D. But if you want to give it, you should give it at higher doses, and for that it's an I because there's not much evidence. So don't waste your time with the low doses. If you believe in it or a patient wants it, or they seem at special risk, go for the higher dose. That's the differentiation, I think.
But they were referring back to the vitamin D recommendation for falls, which was a B recommendation.
Oh, so
they were crossing the
yeah,
two.
they do. So that's that example I gave here of if you just want to prevent falls, you get one analysis of the data. If you want to prevent fractures, another one. And if you want to prevent heart attacks, no good at all. But that's not what we do in life. And this has been one of my quests as a family physician, and it's true for the rest of the primary care and geriatric clinicians too, is that there are a lot of guidelines on what to do with your diabetic patient, or your patient with hypertension, or your patient with depression. And I've never had a patient with diabetes. I've had a patient with diabetes and hypertension and depression and vaginitis and a kid on drugs and a husband that drinks too much. That's what I have. And so the fact they crisscross happens. The development of clinical guidelines or for prevention or management for patients with multimorbidity, which is almost everybody, and certainly everybody when you're talking about the older patient age group, is one of the most fundamental conundrums we face in medical science now. We don't have the methodology to be clear about that. The reductionist method of isolating one variable and finding out what works for that variable does not serve very well in taking care of real patients.
And following up on the vitamin D theme, what about vitamin D preventing depression, especially in Washington, where we don't get much sunshine? I'm not sure there's an answer to that.
We have not, to my knowledge, done any review of vitamin supplements with the outcome of depression. My strong suspicion is there's literally no useful evidence on that. But sometimes I give a talk, I have a list of what comes next, the prevention pipeline. There's a whole bunch of things that are in the works, most of which I can recite to you, but that's not in the works. There is in the works a revaluation of depression in young people, adults and children, and depression in adults, but not chemo prevention.
Okay. We apparently are at the end of our questions. I'm not seeing anything else popping up. So, Dr. Phillips, I'm going to thank you very much for a wonderful presentation.
Well, thank you very much. It's been a privilege to speak with you all, and I wish you good luck doing the best you can taking care of patients. I have a question.
Okay.
Who can tell me who the man in this photograph is?
That one I know. If you're doing the lower right.
Before you say that, yeah. I showed this to a group of 200 medical students, actually a more typical, and nobody had any idea who it was, and when I told them, they still had no idea who it was.
Because they don't know anymore who
That's right.
Albert Schweitzer is?
It's Albert Schweitzer. Albert Schweitzer is a Nobel Peace Prize winning medical missionary, Christian theologist, and world-renowned organist who died in the 50s, I think, late 50s. But he's an old man.
Not bad for a psychologist. Huh?
Thank you very much.
Thank you.